Recording started.
Hello, and thank you for joining us for our October 28th office hours for the End+Disparities Learning Exchange. We're just waiting for a couple more people to join the room. We see a lot of activity here, so we're going to wait another moment or so until we get started. Thank you very much for joining us. And we'll wait just another moment for a couple more of our friends to join. But I'll get going seriously in just a minute because we don't want to take away from the great discussion that we hope to have with you today. Okay, I'm going to go ahead and get started just to, in the name of time and, as a thank you for those of you who are able to log in on time. If there were any technical difficulties in accessing the webinar, we do apologize, and we'll explore those issues at the end because we certainly want to make sure that you have the best and easiest possible experience joining us for these important discussions around ending disparities. My name is Michael Hager. I'm the Manager of Technical Assistance at the National Quality Center and the programmatic lead for the End+Disparities Learning Exchange, brought to you by National Quality Center and the HIV/AIDS Bureau. Before we start, one of the things that we always like to do is to get a sense of who's participating in our webinars, even informal ones like our office hours such as this. If you could, in the chat room, make sure that your bubble is set to send to everyone, and then let us know a little bit about yourself, your name, where you're calling from, your organization, your role there, anything that you think is interesting or helpful in terms of getting to know each other and also in terms of getting the conversation going. You can see I put a little bit about myself in the chat room to start the conversation, but yeah, I invite you to let us know who you are and where you're calling from today. And while people are entering this information in the chat room and kind of doing the get to know each other, I'm going to move on and let you know a little bit about this learning exchange in case this is your first interaction with us. This learning exchange is a 9-month initiative that's intended to promote a community of learners and discussion around ending disparities in HIV health outcomes for key service populations within the Ryan White HIV/AIDS program community. It's a national initiative, and all Ryan White HIV/AIDS program recipients and subrecipients are invited to attend, and other folks, too, who are engaged in this work and interested in helping to make a mark on disparities in HIV health outcomes, namely consumers. Personally, I'm a consumer. I've been HIV positive for 14 years, and I fully appreciate and understand how challenging it is for people living with HIV who aren't part of the service industry here to join these calls, but we really value your input and your time and your perspectives in this work. The Learning Exchange is a set of webinars supported by office hours like this one that are a little less formal, where we can come together around a core set of issues or questions during an office hour, and then turn it over to you, the Ryan White HIV/AIDS Program community participants, to have a discussion around ways that we can use different tools, different interventions, and different strategies to really make a mark in ending disparities in HIV health outcomes in the populations that we serve. One of the major things that we have as a way to learn about the Learning Exchange and to spread the word that the Learning Exchange is taking place is our video. And we invite you all to view the video and to share it widely with your colleagues and your social media contacts. By drawing attention to disparities as a national issue in HIV care, we're going to build more momentum and more passion toward helping to resolve those disparities. Rome isn't built in a day, and we're not expecting that we're going to end all disparities by, June of 2017. But we really hope to make a difference and really hope to make a mark on this. And we hope that the video is inspiring to you. I know personally I'm very inspired every time that I watch the video. On the call today, we do have our director, Clemens Steinbach, and we have one of our federal partners, Emily Chu. And at this time, I'd like to invite Clemens and Emily to make some welcoming remarks to all of you who've joined us today for our office hours.
Emily, do you want to go first?
Sure. Thanks, Clemens. Hi, everybody. Welcome to the office hour this afternoon on a Friday afternoon. We're very happy to have you join us today for the End Disparities Learning Exchange office hour. NQC has put a lot of thought and work into this effort, and so we're really excited to see it moving forward, and we're happy that each of you are deciding to be involved. So please don't hesitate to ask any questions that you may have or offer us ideas or feedback. The beauty of the Learning Exchange is that this is really us giving you information that you're requesting and what you need to learn and really meeting you where you are. So it's a new and different initiative than what we've done in the past, and so we're really excited to work with you and to hear your feedback throughout this process and through June that Michael had mentioned. So I'll turn it over to you, Clemens.
Thank you so much, Emily, for your words of encouragement. So hi, everybody. This is Clemens Steinbach, and I'm really pleased that so many of you could make it today. I know it's tough to take a 1 hour off in your busy schedules, particularly on a Friday, but hopefully we make this hour worth your time. I think by thinking about disparity, it is one step towards really ending the epidemic. And I just want to reemphasize the importance about disparity, and which was really the motivation to think about this initiative. And so I'm thankful for all of you participating. I also want to highlight our presenters for being on the call today, and we couldn't thank you enough. And lastly, I also want to thank Michael Hager from our office for spearheading this initiative, for his many contributions and contributing so much for this initiative. So I want to thank him publicly. I know that this is a exchange, so I hope that everybody just speaks up. The more we hear from you, the more we can respond to, and therefore the calls will be hopefully helpful to you. So thanks so much, and Michael, I'll turn it back over to you.
Thank you so much, and thanks again for joining us today. Our call today is really focusing on a discussion around what tools, resources, and offerings we have available to you through the End Disparities Learning Exchange. It's a little bit of a whirlwind, and really we're trying to just introduce some of these concepts without going into too much detail. We want to make sure that you have an opportunity to ask us questions and raise any concerns and make comments about the offerings that we have planned for you through this Learning Exchange, and who knows, you'll probably have plenty of great ideas for other things that we might consider along the way as we deliver this, this important initiative to you that's aligned with the National HIV/AIDS Strategy. So at this time, I would like to introduce Dolores Dockery. Dolores is one of our consumer consultants at the National Quality Center, and she has decades of experience doing both national and international HIV service planning. And she's going to talk a little bit about one of our offerings that is called Partners in Care. So Ms. Dolores, I'll turn it over to you. You can tell me to advance next slide when you're ready each time.
Great. I'm really happy that we have so many people on the line in this webinar. And I'm really happy to talk about Partner N+Care. Partner N+Care is a model of involving people living with HIV in really reaching the goals that we want to achieve of ending disparities and increasing viral suppression rate. And this framework pretty much has 3 components that I'll tell you a little bit about. And it is the Partner N+Care is really drawing on the experience of people living with HIV. And so it is an opportunity for people living with HIV to become involved in the end+disparity learning exchange and be involved in the work that happens in their clinic as we work towards increasing viral suppression rate and increasing retention rate. So the 3 components that we have is, as you can see on your slide, is the mentor, the ambassador, and the architect. And they run along a continuum. So it's really, you become involved based on what is comfortable for you. So let's think about the mentor. The mentor is some of the personality traits of that person is somebody who has strong interpersonal skills. They're comfortable in one-on-one situation. They have knowledge of self-management techniques and tools in their own care, and they have the ability to provide techniques and tools for self-management, an ability to share their personal success story and relate as it relates to retention in care and self-management. And they have the ability to express the advantages of being a part of the campaign for the consumer perspective. So you might be that person, and you have these traits, and therefore you are able to bring that to the discussion. Most importantly, though, when you're in your clinic setting, you're prepared to be a voice in the clinic. You're prepared to share your experiences and offer peer support, especially when you look at issues around adherence skills and social support, disclosure skills, and self-management skills. And that's what you bring to your clinic. But then there is more that you can do, and you might see yourself as an ambassador. Next slide, please. And what are some of the personality traits for the ambassador? You might be more willing, you might not have, you're very comfortable around disclosure of your HIV status. You're comfortable with public speaking, and you have time to share your story. You're willing to become familiar with +Care, campaign goals and local programs and the tools that we have. And you're aware that as a spokesperson, you'll be viewed as a role model for people living with HIV. And so you will probably take a more active role in your clinic setting as it involves quality improvement. You're establishing your own voice, and you're able to identify your own narrative. You're willing to write testimonials about retention programs, and you're willing to do presentations to the community and really engage other consumers, other people living with HIV, and to discuss the issues around retention, why retention is important, how that will help us to get to viral suppression rates, increase viral suppression rates along the care continuum. You're definitely more knowledgeable and willing to be that spokesperson, but willing to communicate with your community at large. And then the next phase is the architect. And what are some of the personal traits for this individual? Well, they're interested in helping to design and implement and evaluate quality improvement projects. They're probably the people who are willing to sit on quality improvement committees They love data and the processes around that, and they're able to attend and participate in regular team meetings. They have the ability to learn independently about quality improvement and HIV treatment and care, and the values that are important to consumers' input into quality improvement activities. And so what are they able to do in their clinics or even in their EMA and TGAs? Next slide, please. The task that they will take on is to ensure that there is broad community input, really galvanize and mobilize community members, whether those are in their clinic setting or in their planning councils. Really be engaged in consumer advisory boards in quality. They're willing to join clinical or organizational quality management team. And they want to continuously build the personal capacity for quality among all the stakeholders, but in particular among consumers, whether they be in their clinic setting, and again, whether they're in their planning councils or other community-based advisory board or committees. So on our website, you will see there are different toolkits for these different levels of engagement. And, you know, in other webinars, we will discuss these in detail and provide more information. But until then, we encourage you to go to the website and Disparities website to learn more about these things. Oh, great. Has put up the website, and you will see we have a link, Partner N+Care, and there, you know, we will gradually build more and more information in this website, but you can explore some of the basic things that I have just covered, and you will learn more about the toolkits as those come on. So thank you.
Thank you very much, Ms. Dolores. And since this is an informal call, I did take the liberty of going ahead and navigating to that page to give you a little bit of a sense what you'll see on that page. So I think we have time for questions and discussion around Partners in Care as an important aspect of this initiative. We can probably spend about 10 minutes on questions before we move to our next topic, which is on disparity calculation tools and also on improvement intervention sharing tools, which are other very important resources for this initiative, the End Disparities Learning Exchange. So for those of you who are either consumers or providers in the RYMI HIV/AIDS program community, let's talk a little bit about challenges that we've had in engaging consumers in the past, and I'd really appreciate a discussion around whether you think this Partners in Care tool as described is one that is going to end up helping us to really push that envelope in terms of consumer involvement in these important discussions. Any comments or thought or feedback on Partners in Care and its potential to help involve consumers in this initiative?
Michael, I saw on the website that there was an upcoming webinar related to the Partner in Care in November. Do you want to talk a little bit about that as a next cursor?
Yeah, absolutely. We are finalizing those toolkits that Ms. Dolores had mentioned. The toolkits have just so many resources. I'm like, what's the word? Just so many seems like, I guess, the best one. You know, there's a plethora of resources available for the individuals interested in pursuing these roles or individuals in RYMI HIV/AIDS program recipients agencies who are interested in wanting to bring consumers to the table in various capacities. And we all know individuals who are kind of like the light of the community or popular opinion leaders, or we might be those popular opinion leaders ourselves within our own consumer communities who are able to bring this discussion to a greater audience and into our into our circles of friends, into our support groups and CABs and our board committees and other ways in which we're already engaged in the community. So we'll be having a discussion about that on November 17th. We have a double-header webinar scheduled that will be from 1 to 3, and the portion that we're going to be focusing specifically on Partners in Care will be from 2 to 3. So if you're interested in learning more about Partners in Care specifically and consumer involvement as far as it relates to the End Disparities Learning Exchange, we warmly invite and welcome you to join us on November 17th to that webinar where we're going to be discussing this in greater detail and walking through, hopefully, those toolkit resources a little bit and giving you a better sense of what's in store for this.
Hey,
Thanks
Michael,
so much.
it's Emily.
Hey, Emily.
I'm reading from the chat room. Justin shared that he's really excited to share the toolkits with his consumer group focused on quality A4Q. He thinks this campaign will give them some additional structure for talking about disparities and how to talk about that to other consumers. Hey, Justin, would you mind unmuting yourself and sharing what A4Q is?
Hello?
Hello. Yep, we can hear you.
Yep. Great. So, yeah, in our Washington, D.C. EMA, we have a group of consumers that has done some NQC trainings to be able to kind of do some quality technical assistance with other consumers. So they go around to the various clinics in the EMA, and they do little quality trainings. And I think this campaign, because they've been kind of doing the same 101 kind of level stuff for a while now, and I think this campaign is going to hopefully give them a new area of focus. And this is something that is really important to them, and they talk, disparities come up in every conversation they have. But this, I think, is going to give them a little bit more structure, a little bit more knowledge on how to kind of address these big questions that don't, always have answers for easy answers.
Great. Thank you for that. Does anyone else from across the country have any insight or questions or thoughts on consumer involvement and Partners in Care?
Hey, Michael, this is Julia from the Duke site.
Hey,
I'm
Julia.
showing up as a guest on there. I really am looking forward to sharing this with my CAB as well. I think that our CAB will be very interested in caring about the End Disparities program. We're meeting later on in November, but I think that it'll give them some different ways to look at the work that we do. So I think that I echo the previous speaker, the previous gentleman as well, that it is really great to see this go on and kind of think about how this goes through the minds of our consumers who really are living a lot of these problems, and that we're there, that we're looking actively at it, and that they get to be part of that.
Great. Thank you for that feedback, Julia. The Partners in Care toolkit and framework was constructed over the lifetime of the In Care campaign, and a lot of consumer input went into building this, from people living with HIV all over the country, people who were relatively newly diagnosed, and people who are long-term survivors. So there's a lot of different ways to think about the opportunities that we have as individuals living with HIV to get involved, and we're really excited and hopeful that CABs such as yours at Duke and A4Q in DC and so many other places around the country will really, be able to grab onto this and run with it.
And I think also, Michael, that what it does is it acknowledges that people living with HIV come to the discussion at different levels, and it really says to everybody, these are three strategic ways that you can be involved, and you can be involved at the level you are ready to be involved. but we all can play a part as we look at quality improvement and really reducing our retention rate and getting to increased viral suppression rate.
Fabulous. So I'm going to go ahead and move on to our next topic, which is the NQC disparity calculation tools. And I'd like to turn it over to Justin Britannic from the DC EMA to help us walk through this and talk a little bit about his experience in using the tool as he walks us through.
Thank you, Michael. I'm really excited to share this tool with everyone this afternoon. In using this tool, it's been so helpful on cutting down a lot of time spent doing analysis, and you can really get down to making kind of improvements and seeing. It saved us a lot of time doing data analysis, and we're really thankful for NQC for putting this out here. So this afternoon, we're just going to kind of do a tour of the workbook. We're going to kind of go through each of the tabs, and by the end of it, you should be able to understand how to use it. Okay, go ahead and next slide. Yep. So our first tab is the instructions tab, and this is pretty much just an overview of the tool. It kind of has, as you saw on the last slide, what is going on in each of the tabs. There's the basic stats tab, the data entry tab, and then it has some kind of more detailed tabs that have your results, and then it has some summary tabs as well. And then additionally, it has recommended next steps for analysis and kind of ways to determine, the relevance that these outcomes in this workbook have to your QI efforts. And last but not least, some questions area in case you get stuck. Okay, so this is probably the most important tab in the whole workbook from using it. This is where you're going to enter your data. And in the Excel book, it looks exactly like this. And just a quick thing I just want to, because we had questions about this in the past, is that this is not a sample of data. So we're not taking a random sample and looking for disparities. We're using your entire population, and you may be one agency, or you may be like me, and I'm putting the data of 27 clinics or 30 clinics into this tab here. And you see, you're probably very familiar with the numerator, the denominator, and the percentages. And we're going to put those in for each of the groups that have been identified, and we have the two measures. You see number 3 and 4, that's our viral load suppression measure and our HAB medical visit frequency measure. And then lastly, if we have any data limitations or comments, something's going on with the EMR, something like that, that's where we put that. And pretty much what it's going to do is going to compare your total with the outcomes for each of these groups. Okay, so then we have this instruction tab. This is just kind of the flow, like a great flow sheet for how to use this. And I'm not going to go through every single one of these boxes here, but it's kind of just the basics for collecting data for one organization on the top, and then the bottom is the group or network-wide. So if you're doing an entire EMA or maybe a regional group or learning collaborative, then that's the bottom. Okay, so our next tab is Stat Basics, and I know some people kind of get scared when they see math, but don't be afraid. All the heavy lifting has already been done by the Excel worksheet, and that's what's really great about this thing. So what it does here is it is going to identify analysis for the groups that are already laid out in the National HIV/AIDS Strategy, and it's going to calculate the disparities as defined by disparate impact. And that's really important, I think, because it's something where there's already been a precedent set by the Supreme Court. So it's not, they're like, you've all heard the saying, oh, there's lies, dirty lies, and statistics. Well, this kind of like, it takes a little bit of the guesswork out because we're using something that's already been recognized as a best practice. And that's what I think is another really great thing about this tool. So we're going to kind of take a look through each one of we'll talk a little bit about confidence intervals and probability coming up a little bit later. Okay, so here we go. We have the data entry tab, and
You already talked about that one, so yeah.
Yeah, we already talked about that one. So we'll skip right ahead to analysis. Okay. So here what we're seeing is kind of a detailed breakdown. Once we put all our data in, we're going to click the button to go over to the next tab, and it's going to give us our detailed breakdown of our data. And this is kind of, these slides are showing the kind of the power of the disparity. So this is the absolute disparity. So if you see kind of that the red and green bars, so those are kind of showing us that these are great tools because they kind of let us see the cutoff for how we're defining a disparity. And so this one is, so we're talking about odds ratio, so a measure of association between a status and an outcome. And just for those of you who might not know what we mean when we say status, so for example, in this case, race could be a status or age could be a status. We're talking about youth. And an outcome is just a percentage of patient achieving or not achieving the measure. And so our odds ratio is based on odds. The lower the odds ratio, the higher the probability of a disparity.
And I think an important thing to mention here, too, if you don't mind me interjecting, is that a lot of people who are statisticians or scientists are skeptical of tools like this because they say, I don't see p-values, and where are your other, confidence intervals, and the other ways that we can make sure that the information that the odds ratio or relative risk measure is showing us is valid and reliable. You can see here that we've actually built confidence intervals into the odds ratio calculation and the relative risk calculation. So this is something that if you are, more advanced in your statistics and you're curious to see, what that confidence interval is and to understand how that might affect the validity of an output for that calculation, this information is available to you here. And the calculator automatically determines if something is outside of what we would have as an acceptable confidence interval. It's listed as no disparity. And the example you can see here is for transgender people disparity odds. If you calculate based on just the data alone, it looks like there is a disparity. It says odds ratio 0.42 and it's red. But if you know anything about confidence intervals, you can see that the confidence interval includes the value 1. So since that makes this a null value, then a null output, because anytime a confidence interval includes a value 1, we throw out that result. So that's why this is marked as no disparity. And that's a little quick and dirty statistics lesson for you if you're not familiar with statistics and how to apply confidence intervals to measurement.
Thanks, Michael. On this next slide, again, we're going to talk about analysis with the absolute impact. So that's the absolute disparity multiplied by the size of the population experiencing the disparity. And this one it's very helpful to see how many lives we can affect by introducing, if we're going to tackle this as a QI project, what's going to give us the most juice for the squeeze and the most bang for the buck. And in this one, you can see this example. In our example, we have transgender people, and there's only one. So if we do a whole project to eliminate disparities among transgender, this sheet here is telling us we're going to impact 1 life, whereas with an African and American Latino women, a project around that, we might impact 8 lives. So we may want to start there. And this next tab is the summary tab, and this one is kind of very helpful. When I was working with the calculator, I actually would start with this one and then kind of work backwards to kind of see the details afterwards. So that would go to this, because this is kind of like, I think of it as your control panel. So we have all the populations up top, and then we have the calculations for, the different methods of calculating disparity along the left side column there, and we can easily see yes disparity, no disparity. So and it has the absolute impact along the bottom. So this is just a really great place. And once you plug in your data, you can go here and kind of just see, where are there the most disparities and where could I possibly have the most impact. And this is a great slide, I think, for kind of determining, maybe what your priorities should be.
Great. So that is a quick presentation on the disparity calculator. I'm wondering if we have any questions about that. And in the meantime, I'm going to show you, while you're thinking about your questions, I'm going to show you how to find it. If you come to the end+disparities.exchange.org website and click on resources, you'll see a number of resources, and the calculator lives right here. These slides, just to help frame the conversation and to generate questions that you might have today, were actually drawn from Part 3, How to Use the NQC Disparities Calculator. These slides and the recording of this presentation we're having, this conversation we're having now in office hours, will be made available to everyone. But if you wanted to come and download a little how-to about the calculator and learn a little bit more about why we're focusing on these populations, why we're focusing on disparities at all, what this calculator is, some of the assumptions behind it, and then also some of the next steps you can take after using the calculator, you can find them all right here at the end+disparities.exchange.org website under Resources and then under Disparities Calculator. You can see that there is also the workbook itself available here, and also a written guide that provides a how-to description and also just a narrative about these measures and the Supreme Court of the United States precedent that disparate impact is set for us to follow here in healthcare.
Hey, Michael, it's Emily from HAB. So we got a question in the chat box from Kimberly D. I was asking if anybody had played around with the calculator yet, and Kimberly hasn't, but she plans to, and she had a question about how Black and Latino women are placed in the same category. And I thought if we can share your screen just to go through a demo of how to separate out those two populations. The workbook was formulated, the populations that are there based on in-house indicators, which is what we utilize for the learning exchange, but the fields can be edited to some capacity. And so if you can, Michael, I know I'm putting you on the spot. I'm not sure if we can run through this now to show her how.
So at the outset of this initiative, we have not unlocked these fields for people to edit themselves, but this is something that if you're interested in having a discussion with me, Kimberly, I'm happy to separate them out. It's as easy as just changing the text in these boxes here in fields A9 through A12, and then that reflects its way through. So if you wanted this to say just African American women in 11, then as you click through, you change it in that one location, and it'll reflect the change here and in each of these boxes as we work our way through, just to make your life easier and to make the discussion you have with your clinical leadership, consumers, and other stakeholders easier. So thank you very much for that question, and thank you, Emily, for bringing up the fact that these are editable as long as you have a conversation with me. And I promise I don't bite, and I love working with people from all over, so definitely take me up on that.
Thanks, Michael. And thanks to Kimberly for your question, and Justin, thanks for responding too as well in the chat box. And keep the questions coming in the chat box. I can respond to them or bring them up in the office hour as appropriate.
Absolutely. I saw that there were some questions lingering on partners in care that came after we switched topics, and I will return to those questions after we have a chance to talk about some of these other tools. I hope that's okay. So, you know, you'll see when you walk through these different PowerPoint slides, or if you join us on the 17th, we're also going to be talking about each of these tools in greater detail then as well. You'll see that there are some good solid next steps suggested there in terms of what you can do with this information. And I want to just take a moment to click on the Interventions tab. Here we are at the end+disparities.exchange.org website again. If you click on Interventions, you can see our intervention grid. This grid was put together with the input of researchers from around the country working on disparities, working with these populations, and individuals who are familiar with the Ryan-White HIV/AIDS program. Some of these interventions were also proposed by the folks who have been intimately involved in the SPINS projects recently that have focused on these populations and other populations regarding retention and viral suppression. So just to give you a sense of what this is like, If you click populations, you can see that we have our 4 populations at the top. Let's say that I'm interested in working with MSM of color. I can click there, and I'm navigated to the bottom of the page here where MSM of color are located. And we can see practice-based evidence seminars. So we can learn a little bit more about these. They are owned by the Agency for Healthcare Research and Quality, or AHRQ. You can click here to see a little bit more about that intervention itself. Call for applications across the U.S. based on activities. It worked with youth and MSM of color. It affects retention and viral load suppression. And it was a 2-day summit. We listed this as something that is somewhat costly because it has the summit itself and then follow-up. And really the idea here is that you take this type of conference and you do this within your own locality. You can have people from across your city or from across your part of the state come together and really put your heads together around this type of problem that is with the MSM of color population or the youth population, and really start to dive deeply. Personally, I think that you could have a conference that is built along these lines that goes with any population, although this one was specifically recommended for MSM of color and youth as a focus. Let's look at another example, peer or paraprofessional navigators. We can see resource link here. This is actually to an article that appeared in the literature. You could click that to be navigated to where that article lives on the interwebs. But if you click details, once again, we can see a description of what this intervention was, a little bit how it was organized in terms of its cost and its inputs. And we can see that this came from the International Association of Providers in AIDS Care. So this is one of the places where you can go to learn a little bit more about, ideas, things that you can try that might work with the population that you've decided to focus on. And just to show you that, you can click any of the different populations and there are different interventions available for all of them. If we go back to all interventions, we can see that we can select by the care continuum stage. We're focusing on this, in this initiative, we're focusing on retention and viral suppression. So you can navigate that way. And the last way that we can look at this is looking at intervention type. Capacity building, case management, experience evaluation, health systems, outreach, and patient-focused interventions. So there's a lot of different ways to think about the type of intervention that might be appropriate for people in your service system that you're trying to serve. Now, our other tool that we have to help navigate interventions and to do some project selection is called NQC Share Lab, and you can see the link there is nqcsharelab.org. You can also access it directly from the end+disparities.exchange.org website. It's a link there as well. And this is a really neat tool that we've had for a couple of years. This was also born out of the In Care campaign. And if you click the bubbles, it just opens up more bubbles that tell you a little bit about what you can try with the different populations and also things that you'd like to explore. When you come to these interventions, you can click on one to read a little bit more about it, and it's fully described here. And the thing that I really like about this tool is that you can click on the person who submitted it, and you get the contact information for that person. Sometimes just picking up the phone and calling someone and asking them, colleague to colleague, about what they did and why they did it is going to end up being golden for you, because there are going to be nuances in our patient populations and in what we're doing with folks, and it's really helpful to just kind of talk through some of those implications with the person who makes these postings. So now that I have shared all of these different tools and opportunities with you, I'm wondering if we can have a discussion around these different resources and offerings. We told you about involving consumers. We told you about what you can do to help measure what disparities you might have in your clinic population or network population. And we also showed you ways to find solutions to high priority populations that you identify based on those measurements. What do we think?
Michael, this is Clemens. I wanted to share a little bit my experience. I had the pleasure to go up to Cleveland to visit the EMA there recently, earlier this week. And one thing we actually use the calculator for is to really think through what is the one QR project we want to focus on for the upcoming year. And so we did the following, and I'm just bringing it in so that you can see how this tool can be used by one clinic, but also by an EMA or Part B for that matter. And so what we did was we used a calculator, and we actually entered the TGA-wide data to see what the rates are, and then really had a conversation about what should be the focus and which group and disparity-wise. And that was a very important discussion because we went straight for what can we do about it and which is the group, rather than debating which group is more important than the other. And I think the tool gave us a good map going forward. And then another expectation that we did was that every subrecipient in the EMA was asked to get the calculator, download it, enter their own data, since we know the disparities are local, and then and they all were given a couple of weeks to actually enter the data, identify one subpopulation they want to focus on, and then submit not only the data, the screenshot, but also figure out the first 3 steps in the right direction to address subpopulations. I just want to share that as a way to think a little bit about how this tool is actually being used already. And they had echoing what Justin and others said. It was very helpful, and it really cut through this kind of anecdotal data reporting and went straight down to, this is what the data tell us, let's think about what we can do with it. So just wanted to share that with you. So.
Thanks so much, Clemens. So I'd like to return to a question from, or a comment from Angelique Crosdale. Angelique from Hartford mentioned that there were some consumers that attended the NQC training, the Training of Consumers in Quality Plus, and they came back ready to hit the ground running and have already hosted a one-day training with over 12 consumers, and they'll be providing a training to the Planning Council committee soon. And that's a really great reminder, Angelique, thank you, that the National Quality Center has a program called the Training of Consumers in Quality. It's a way to not only think about health literacy, but health numeracy, which is an area where all people struggle, not just consumers, but especially, you know, consumers who are looking to become engaged in this work oftentimes are at a disadvantage. Like usually if we're working for an agency, we have some basis of understanding, you know, the math involved with these types of simple statistics. But the Training Consumers in Quality really helps consumers build that foundation for themselves. And the plus is that folks that are alumni of this program are then expected to return to their home communities and to provide these trainings to other consumers. This model was built somewhat, you know, on the back of the A for Q models that we heard Justin describing earlier, where consumers are perfectly capable of being self-advocates and in training each other and in helping each other learn some of this stuff and make it less magic and more science. So thank you, Angelique, for that comment. So what do we think? These tools and resources are the main ones that we have available through this learning exchange. In addition to you, I think that our participants are also an important resource because your experience and also just the conversation and discussion that you'll raise as you work through these quality improvement projects around disparities mitigation are going to be priceless. But what do you think? Are there areas that we should consider including or pointing toward or heading in additional directions? Are these tools a really wonderful foundation in your opinion, or give me something to chew on here, folks?
Hi, Michael. This is Justin again, and I just wanted to share some ideas that we've been throwing around in DC because we've had a little bit of time to look at the calculator now. And so something that we came back to is, how can we break this disparity? It's a huge problem. How can we break it down into manageable chunks as possible? And I think the disparities calculator really helps us do that. And by focusing on, probably the one population that is, maybe shows the most disparity or the greatest possible impact, that helps us. But then we also thought, what other tools have we already seen? And one was the cohort measures. So we could possibly do cohort measures for viral load suppression and medical visit frequency. And then so, we're getting any careware reports that are just, looking at that population for those measures. And that's just another way to break it down further, and maybe even get, like, a case manager can get a list of folks in that population who don't meet that measure and just kind of break it down to that really, really local level.
That is a really excellent point, Justin, that for another initiative that NQC and HAB co-delivered recently called the HIV Cross-Part Care Continuum Collaborative, or H4C for short, our friends at CareWare actually developed a cohort measure that can be used in careware to help track a population over time. And, that's a really wonderful application of existing tools, Justin. Emily, I don't know if, are you comfortable providing a little bit of a description of the cohort measure, or do we want Justin to describe it because he's experienced in the field with it? Emily says,
okay,
Justin.
I just saw that. So there's probably other people who can describe it better than I can because they were really, really involved in that initiative. But essentially what it is the measures the measure for viral load suppression was looking at a fixed cohort over a period of time. So instead of having that rolling data where sometimes we can never quite, meet that goal because we're always getting new patients coming in who may not be suppressed, we were just looking at kind of this one fixed snapshot in time of data. And the only reason I think folks were removed was if they were documented to have, moved out of the geographical area or they became deceased. So I think that kind of really kind of narrow focus, I think, was one of the things that was saw such phenomenal outcomes in that initiative.
Very true. By the end of the initiative, 45% of people who were not virally suppressed at the outset of the initiative became virally suppressed. That is an adjusted figure based on submissions. But, all things being equal, we anticipate that it was probably around 40% across the board if we were able to, get submissions from everybody who had initially provided data to us. So thank you so much for that, Justin, and yeah, I really appreciate that.
Hey, Michael, this is Julia. I know this isn't really a community, talking about the community right now, but I'm thinking about it with our subrecipients and inputting the data that we have and then going back to our subrecipients and sharing the output from the calculator and saying that, this is just another form of a way of us to encourage that quality improvement at the subrecipient site. We're doing it with our data right now and giving them percentages, but when we can actually look at things in terms of specific groups and saying this group is not doing as well, and really kind of getting them to focus more on their quality improvement efforts.
Absolutely, absolutely. I think that it's a priceless tool to just drive that discussion about clinical quality management and ultimately quality improvement within your set of subrecipients. That's a wonderful idea and great point, Julia. Thank you. Okay, we have about 5 minutes left. Does anyone else have any questions or comments or, you know, dare I ask, concerns? Well, I'm really grateful for your participation in today's office hours. These conversations are meant to be informal and an opportunity for folks to hear a little bit more detail or to get a sneak preview on something that's coming around the pike in this learning exchange. But really importantly, it's an opportunity for you to interact with each other in an informal, comfortable, safe way, and also with all of us at the NQC, with our federal partners, and with other key stakeholders in this initiative. So be on the lookout for our office hours. They occur on Fridays at 1 o'clock, not every Friday, but you'll see on the end+disparities.learningexchange.org website the list of office hours that we have populated through December. We're looking at strategic planning next week in terms of how you build aim statements and do root cause analysis and that type of pre-planning for a quality improvement project that addresses disparities in HIV health outcomes. We'll also be having a conversation about helping consumers understand baseline data when we get further into November. So we really look forward to engaging you around this subject matter and having more conversations about how we could be as effective as possible in designing our quality improvement projects that address disparities. Thank you very much, and thank you for the wonderful comments and kind words that we see in the chat room. Have a wonderful day, and we'll see you next time.
Thank you. Thanks, Michael.
Thanks.
Thank you.
Thanks.